Drugs in cough and Introduction to drugs in asthma. Dr. Venuti. Cough. Cough is a protective reflex. Types. Non-productive cough. Productive cough. Productive cough. Its suppression is not desirable, may even be harmful. Not useful. Useful. Causes. Commonest cause of acute cough, lasting 3 weeks, is respiratory viral infection. Many causes. Centrally acting antitussives. Opioids like codeine and codeine. Non-opioids such as dextromethorphan, noscapine, and p-pazothate. Suppressing cough center that mediates the cough reflex. What are the side effects possible? Codeine. It is a semi-synthetic opioid analgesic. Potent cough suppressant action and can be administered orally, 10 mg BD or TDS. Lesser addiction liability and lesser constipation. Overdosage can result in respiratory depression, convulsions, postural hypotension, and tachycardia. Full codeine. Full codeine, it is structurally related to codeine but is slightly more potent, longer acting, and better tolerated than codeine. It causes lesser constipation and drowsiness than codeine and is more suited for long-term use. It is also given orally, 10 to 15 mg BD. Dextromethorphan. Methylester of the dextroisomer of levorphanol. A synthetic central NMDA receptor antagonist. It has least addiction liability, no analgesic action. Least constipating effects and minimal drowsiness. As an antitussive it is as potent as codeine and is given orally, 10 mg TDS. Noscapine. It is a naturally occurring opium alkaloid belonging to benzylisoquinoline group. It is devoid of analgesic activity, drowsiness, and addiction liability. It has minimal constipating effects and is also a popular cough suppressant. It is given orally, 15 mg TDS. High doses may produce nausea, headache, and tremors. Central as well as peripherally acting antitussives. Benzonatate is an antitussive structurally related to the local anesthetic tetracaine. It not only inhibits the afferent cough impulses to suppress the central cough center, but also inhibits the pulmonary stretch receptors and, therefore, has both central as well as peripheral mode of action. It is administered orally, 100 to 200 mg TDS. Side effects include drowsiness, nausea, headache, and in high doses, vertigo. Peripherally acting antitussives. Prenoxdiazine acts by inhibiting pulmonary stretch receptors to relieve bronchospasm. It has a moderate antitussive action and is administered orally, 100 to 200 mg TDS. Side effects are mild and infrequent. Demulcents. Local anesthetics. Demulcents. Pharyngeal demulcents soothe the throat and reduce afferent impulses from the inflamed irritated pharyngeal mucosa, thus provide symptomatic relief in dry cough arising from throat. These include honey, licorice, syrup tolu, and syrup Vaisakha. Local anesthetics, such as xylocaine and bupivacaine, can be applied on pharynx and larynx to reduce the sensitivity of sensory receptors for cough in this area. These are typically used to treat the cough associated with bronchoscopy and can also be tried in patients who are refractory to other cough therapies. Antihistamines. Many H1 antihistamines have been conventionally added to antitussive expectorant formulations. Sedative and anticholinergic actions. May even reduce secretions by anticholinergic action. In respiratory allergic states. Though their lack of efficacy in asthma is legendary. Antihistamines. Chlorpheniramine, diphenhydramine, and promethazine. Second-generation antihistamines like fexofenadine, loratadine, etc. are ineffective. Expectorants. These drugs either increase the volume or decrease the viscosity, or both, of the respiratory secretions and facilitate their removal by ciliary action and coughing. These act either by mucokinetic or by mucolytic action. Mucokinetic expectorants. Flow of respiratory tract secretions by stimulating the bronchial secretory cells, to increase the volume, and the ciliary movement, to facilitate their removal. Essential oils, example oil anise, oil eucalyptus. Ammonium chloride. Sodium citrate. Guaiacol. Guaifenesin. Administered orally, 100,200 mg BD or TDS. Mucolytic expectorants. Mucolytics alter the chemical characteristics of mucus to decrease its viscosity and to facilitate its removal by ciliary action or coughing. Acetylcysteine, carbocysteine, bromhexine, ambroxol, dornase alpha. Acetylcysteine decreases the viscosity of mucus by splitting the disulfide SS bonds of mucoproteins. This action is further facilitated by alkaline pH 7 to 9. Cystic fibrosis and chronic bronchitis. Paracetamol toxicity. Dry eyes, keratoconjunctivitis sicca. Carbocysteine. The drug has protected SH group and therefore cannot work through SH and S interchange, i.e., it cannot split the disulfide bonds of mucus. MOA, not clear. Bromhexine is an alkaloid from Vaisaca plant. It depolymerizes mucopolysaccharides of mucus directly and also increases lysosomal enzyme activity that breaks fiber network of tenacious sputum. Usual oral dose is 8 to 16 mg TDS. Side effects: get upset and rhinorrhea. Ambroxol is a metabolite of bromhexine. Oral dose is 30 mg BD or TDS. Dornase alpha. Higley purified solution of recombinant human deoxyribonuclease, DNase, an enzyme that selectively cleaves DNA. Purulent pulmonary secretions in cystic fibrosis contain very high amounts of extracellular DNA which is released by degeneration of neutrophils, in response to infection. Dornase alpha inhalation, 2.5 mg once daily, hydrolyses this accumulated DNA in the sputum of the patients of cystic fibrosis and reduces the viscosity of sputum. Bronchodilators. Stimulation of pulmonary receptors can trigger both cough and bronchoconstriction, especially in individuals with bronchial hyperreactivity. Their fixed-dose combinations with antitussives are not satisfactory because of differences in time course of action of the components and liability for indiscriminate use. Aromatic chest rub is widely advertised as a cough remedy. Though it has been shown to reduce experimentally induced cough in healthy volunteers, there is no evidence of benefit in pathological cough. Fixed-dose combinations of a centrally acting antitussive with a bronchodilator or with an antihistaminic having high atropinic activity have been banned in India, but many are still marketed. Majority of the FDC cough formulations that are marketed and briskly advertised are irrational and have only placebo effect. Warning: antitussives should not be used in cough associated with asthma, or chronic bronchitis or bronchiectasis, as they can cause harmful retention and thickening of sputum. Used only for dry non-productive cough or if it is unduly tiring, disturb sleep, or is hazardous, hernia, piles, cardiac disease, ocular surgery. Morphine is not suitable for treating cough, because of its strong addicting and respiratory depressant property. Introduction to drugs in asthma. Dr. Venuti. Asthma is characterized by hyperresponsiveness of tracheobronchial smooth muscle to a variety of stimuli, resulting in narrowing of air tubes, often accompanied by increased secretion, mucosal edema, and mucus plugging. Causes: an allergic basis. In others, a variety of trigger factors: infection, irritants, pollution, exercise, exposure to cold air, psychogenic. Extrinsic asthma: it is mostly episodic, less prone to status asthmaticus. Intrinsic asthma: it tends to be perennial, status asthmaticus is more common. Pathology: release of mediators stored in intracellular granules, immediate. Histamine, protease enzymes, TNFA. Release of phospholipids from cell membrane followed by mediator synthesis, within minutes PGS, LTS, PAF. Activation of genes followed by protein synthesis, over hours. Interleukins, TNFA. These mediators together constrict bronchial smooth muscle, cause mucosal edema, hyperemia, and produce viscid secretions, all resulting in reversible airway obstruction. 1. Prevention of AGIB reaction. Avoidance of antigen. 2. Neutralization of IgE, reagenic antibody. Omalizumab. 3. Suppression of inflammation and bronchial hyperreactivity. Corticosteroids. 4. Prevention of release of mediators. Mast cell stabilizers. 5. Antagonism of released mediators. Leukotriene antagonists, antihistamines, PAF antagonists. 6. Blockade of constrictor neurotransmitter. Anticholinergics. 7. Mimicking dilator neurotransmitter. Sympathomimetics. 8. Directly acting bronchodilators. Methylxanthines. Thanks. Dr. Venuti.